I presented the data from the COSMIC-021 trial, cohort 6 specifically, in patients with metastatic castrate-resistant prostate cancer who were treated with the novel combination of a oral tyrosine kinase inhibitor, cabozantinib, with a programmed death ligand 1 inhibitor, atezolizumab. So all these patients who had progressive metastatic castrate-resistant prostate cancer after one novel hormonal therapy, such as enzalutamide or abiraterone, were included in this trial and treated with this novel combination. We know that cabozantinib, although it is known as oral inhibitor of receptor tyrosine kinase involved in tumor growth, angiogenesis, and immune regulation, including MET, VEGF, and TAM family of kinases, it also allows an immunopermissive environment through its multiple actions on multiple pathways. And that makes it synergistic with atezolizumab. And in fact, we did see encouraging clinical activity in an earlier cohort of 44 patients treated and reported previously in the 2020 GU ASCO meeting. So based on that, we decided to expand the cohort from 30 patients to 130 patients. So we have presented, as I said, the earlier 44 patient data. And now in this 2021 ESMO meeting, I presented the data on all 130 patients. So a relatively large number of patients for phase 1 trial. So I'd like to first point out the eligibility criteria. What kind of patients were included in this clinical trial? So the number one, the most important criteria was presence of measurable disease, which was progressive radiographically. So patients were only allowed to enroll on this clinical trial who had metastatic castrate-resistant prostate cancer, progression on or after enzalutamide or abiraterone, novel hormonal therapy. So a patient population with relatively poor prognosis, very limited options available, and they had to have measurable disease, either in visceral metastasis or lymphadenopathy, which had to be progressive radiographically. So we had to show radiographic progression in this measurable disease before these patients were deemed eligible. So this is a very important eligibility criteria. And that's why I'm highlighting it repeatedly. So what we saw, so first of all, what was the primary endpoint? So primary endpoint was investigator assessed objective responses by RECIST 1.1. Because all these patients had measurable disease, we decided to choose RECIST 1.1 as a stringent criteria for measuring response. Cabozantinib is known to have its own effect on the bones. So we didn't, and it can make bone lesions look better on the bone scan, and which may not be associated with necessarily improvement in radiographic progression-free survival or improved outcomes. So we avoided using bone scan findings as a marker of response, just to be very solid with our assessment. We decided to focus on RECIST measurable disease. So that's another unique aspect of this clinical trial, which is focused on metastatic castrate-resistant prostate cancer. And there were multiple other secondary endpoints, such as safety, PFS, OS, and so on. So let's look at the results now. So if you look at the investigator assessed responses in this patient population, overall objective responses were seen in 23% patients with 3 confirmed complete responses. If you look at objective responses in patients with visceral metastasis or extrapelvic lymph node metastasis, so these patients had to have lymph nodes above the aortic bifurcation we saw 27% responses, objective responses, with 2 confirmed complete responses. And this was the primary endpoint, investigator-assessed responses. Beyond the responses, we also saw a high level of disease control rate. So very few patients actually had progressive disease as the best response. So beyond response, if you look at patients who had progressive disease, who did not have any shrinkage and continue to have disease progression, only 15% patients had progressive disease at the best response, or less than around 15% patients if you look at all the cohorts. So if you look at stable disease and complete response and partial response, we call as disease control rate, it was present in more than 80% patients. So disease control rate was present in more than 80% patients. We also assessed the responses by independent radiology assessment. Although it was not a primary endpoint, we still decided to do that. So if you look at the objective responses by radiographic assessment by independent blinded radiologist, the objective responses were 15% in all patients and 18% in patients with visceral or extrapelvic lymph nodes. So the response in the investigator assessed responses were obviously higher by almost 7 to 9 points compared to the independent radiology assessment. But then you look at the disease control rate, even by independent radiology assessment, it was still more than 80%. So I think it was a measure of, if you look at the target size reduction. So let's not look at response for a moment. If you look at just how many patients had shrinkage in the target lesions, 77% patients had a shrinkage in the target lesions by investigator assessed criteria, and 70% patients had reduction in the target size lesion by blinded independent radiology. So again, not much difference overall. And these waterfall plots are present in slide 7 of my presentation, if you would like to have a look. Now let's look at the radiographic progression-free survival. It was a secondary endpoint, and radiographic progression-free survival was 5.5 months in all patients by investigator-assessed criteria, and 5.7 months by independent radiology assessment. If you look at high-risk patients who had visceral metastasis or extrapelvic lymph nodes, these are 101 patients, they had a investigator-assessed PFS, a radiographic PFS of 5.6 months. And by independent radiology assessment, the PFS was 6.8 months. So again, it is remarkable that patients who had extrapelvic lymphadenopathy or visceral metastasis, we saw a independent radiology assessed radiographic progression-free survival of 6.8 months, almost 7 months. Regarding the safety, so again, all these objective responses, stable disease rates of more than 80%, radiographic progression-free survival of almost 6 months in all comers and almost 7 months in patients with visceral metastasis or extrapelvic lymph nodes by independent radiology assessment is quite impressive. We also know that PSA responses, when we see PSA responses, it is comforting. As prostate cancer doctors, medical oncologists, we know we see PSA responses, regardless of patient population, drug has activity. And indeed, we saw PSA, some kind of PSA decline in almost half of the patients. 47% patients had a decrease in the PSA on treatment, and half of them had a PSA 50% responses. So from that perspective, I think it was comforting to me. It basically reinforced my opinion about the efficacy of cabozantinib and atezolizumab in this patient population. If you look at the safety of the combination, we didn't see new safety signals. most of the side effects, grade 3 or 4 side effects, were driven by the cabozantinib associated side effects. So diarrhea, fatigue, hand-foot syndrome, oral sensitivity. But if you look at the immune-related side effects, 17% patients required high-dose steroid for treatment of immune-related adverse event. So out of total 130 patients who were treated with cabozantinib and atezolizumab combination, less than 20% of patients required high-dose corticosteroids for treatment of adverse events. The duration of treatment was 5.7 months, almost 6 months in this elderly population. So that is another indicator of how well tolerated the combination is in this patient population who had highly aggressive disease, who have progressed on abiraterone or enzalutamide. In fact, almost half of the patients, 45% patients to be precise, had progressed on both abiraterone and enzalutamide. And we are seeing this patient population to be on this treatment for almost 6 months. So that is an indicator of not only safety, but also efficacy, in my view. So I'd like to conclude by saying that this combination, novel combination of cabozantinib and atezolizumab, demonstrated encouraging clinical activity in patients with metastatic CRPC, which was confirmed by blinded independent radiology review. We saw anti-tumor activity in patients, all patients, as well as patients who had visceral metastasis and distant lymph node metastasis. And specifically, I want to highlight this patient was the patient population who had to have progressive measurable disease at the time of entry. The safety profile was manageable and was consistent with previously reported data. And based on these encouraging results, exciting results, we have already started a phase 3 study known as CONTACT-2 trial of cabozantinib plus atezolizumab in patients with metastatic castration-resistant prostate cancer who have visceral metastasis or extrapelvic lymph node metastasis after one prior novel hormonal therapy. And this trial is already accruing patients in more than, I think, 25 countries across different continents. And I would like you to please consider the trial for your patients. Thank you very much for your kind attention.